Hi everyone, my name is Dr. Abai and I'm here at the Glidewell International Technology Center in our operatory here. And I want to present a very special case for you where we took the patient from implant placement all the way through the delivery of the crown. What's unique about this case is that we utilize an intraoral scanner and a scanning abutment in order to capture the final impression, where the patient presented with a missing molar, first molar. And with the diagnosis and treatment planning, we decided to place the implant with a freehand technique, a traditional implant placement. So we wanted to reflect the flap and create an osteotomy. And this part is obviously very important. We want to make sure that we have enough bone buccolingually. We want to make sure we have enough space mesiodistally, and also the bite of the patient needs to be checked to make sure that we have enough interocclusal space for a final restoration. What's the use of placing an implant if you can't restore it? So the osteotomy was created. Here you can appreciate a very simple flap reflection so that we can visualize the underlying bone. And once the osteotomy was created, an implant was inserted. In this scenario, I utilized the Hahn implant. And it's been a great implant, especially in the molar area with very good primary stability. And what I really like about it is that we have a lot of bone retention when the patient comes back for the final impression for the final restoration. We also have excellent bone retention after loading of the implant, which is going to be really important over time. So the implant is in place, and I'll go ahead and torque the implant to 35 to 40 Newton centimeters, and hopefully a higher torque value means a better primary stability. Once the implant is torqued into place, I'll place a healing abutment and a couple of simple interrupted sutures interproximally to make sure that I have the soft tissue approximated fairly well, and that'll help promote the healing of the area, and the patient will have less complications after the implant placement. So here you can appreciate in the radiograph that the implant was placed in the proper position mesiodistally, and I used the long enough healing abutment so that the soft tissue will not grow over the top of the healing abutment. So I wanted to do a single stage surgery for the implant placement, and when I bring the patient back, then I can take a look and make sure that the soft tissue is where it's supposed to be. I have enough keratinized tissue on the buccal in this situation where I feel comfortable that I can place a final restoration and not have to worry as much about peri-implantitis and other issues that come along. So this is how the patient presented after a period of osseointegration, usually in the site with type 2 or type 3 bone. 4 to 6 months is plenty of time for osseointegration. So once the patient's ready for the final impression, the day of the final impression, I'll go ahead and remove the healing abutment, and now we have to scan abutment in that area. And this is what a scan abutment looks like. It has identification factors that are built into it. In this case, they're just these round dots that you can see in different areas. These scan abutments have 3 different round areas that the scanner will recognize, and it'll digitize all the information and have a reference point for the CAD/CAM system to pick up exactly where the scan abutment is, and in translation, really where the implant is. And you can fabricate a final restoration that way. So this is a radiograph of the scan abutment in place, and you can see that there is a certain level of radiopacity. So you can actually take a radiograph to make sure that the scan abutment is properly seated before you take the scan. Otherwise, if it's not seated properly, we're going to have some issues with the fit of the final restoration, obviously, so it's not going to fit correctly. So in this case, we took a radiograph. We wanted to make sure that the scan abutment is seated completely before proceeding. And once we seat the scan abutment, it's time to take the final impression with a scanner. For this patient, I utilized the Trios 3-shape intraoral scanner. This system requires you to scan the area actually first without the scan abutment in place, so just the soft tissue, and then move on to placing the scan abutment and scanning the area, scanning the posing and the bite. And the only thing you have to relay to the laboratory is the shade of the tooth, and you can move forward with the prescription and send that digitally to the laboratory for the fabrication of the final crown. So once I take the final impression, the advantages of using these intraoral scanners is that you can take a look and make sure that you don't have any areas that are missing in your impression. So you can rotate your final impression You can move it around, and you can blow it up to size so that you can take a look at greater detail at the final impression. And that's what I'm doing right here. The laboratory will eventually fabricate the final restoration first digitally and utilizing CAD/CAM technology. And these softwares are very robust, where you can import from a different libraries of teeth and make sure that you can match the adjacent teeth. And as you can see here, you can really appreciate that this is a molar, but the occlusal table is a little bit narrower. And the reason why we're doing that is because we want the occlusal forces to go through the long axis of the implant. And if you have a wider occlusal table, like the second molar in this situation, those occlusal forces are going to cause shearing forces on the implants instead of compression. And you want to stay away from shearing forces when we're dealing with implant final restorations. So a narrow occlusal table is going to be recommended. So once the fabrication of the final restoration is completed and Glidewell sends the crown back to me, to the operatory, I'll bring the patient back for the final visit, and I'll remove the healing abutment and I'll place the crown. Again, in this situation, it was a screw retained crown, so I placed the crown and I placed the final delivery screw, and I torqued it to 35 Newton centimeters. You can take a final radiograph at this point to make sure that everything is seated properly before you fill in the screw channel or the screw access hole, and that's exactly what we did. So I torqued the implant restoration into place, and I like to restore it with some Teflon and composite. And then I'll go back and I'll make sure to check the occlusion to make sure that we're slightly missing the opposing tooth so that we don't have overload of this implant. And that'll help preserve some bone. It'll also help reduce the fracture or loosening of the screw and different prosthetic components. And finally, I mentioned that we take a final radiograph to make sure that everything is seated. And here you can appreciate the amount of bone retention after months of this implant being in place. And now the true test is making that final impression and loading the implant and making sure that the final restoration is congruent with what we're looking for in a scenario like this. Every step has to follow the previous step, and we try to achieve our final outcome and our final goal as best as we can. So the true test is to bring the patient back now every 6 months when they're going through hygiene appointments, and we can evaluate the implant and make sure that everything's in place and make sure that the patient's also very happy. And here you see a buccal view of the final restoration. Now you can appreciate that there's a little bit of blanching of the soft tissue, which is normal, and this blanching is going to go away in a matter of hours, and the patient will be comfortable after the delivery of the restoration. So in this scenario, what I'll usually do is I'll check the bite of the patient and make sure that I'll utilize some shim stock and make sure that I can pull the shim stock through, and that'll ensure that I am out of occlusion enough where I'll be comfortable with that final restoration. Well, thank you for joining me for this article for Inclusive Magazine, and I hope to see you back here at Glidewell Dental Laboratories for more cases in the near future.
This is Dr. Timothy Kosinski from Bingham Farms, Michigan. Practitioners have much to gain from using an intraoral scanner to capture the final impression for implant restorations. Intraoral scanners are highly accurate and eliminate the need to send physical impressions to the lab. Further, at Glidewell Laboratories, restorations produced from digital impressions are offered at a significantly reduced fee. In Figure 1, we see an occlusal view of the edentulous site. Please note the adequate amount of attached gingiva present. In Figure 2, we see the periapical radiograph of the edentulous mandibular first and second molar areas. The MD guide from Golden Dental Solutions was used as a tool to help determine proper mesial distal spacing and visualize the final emergence profile of the molar crowns during creation of the initial osteotomies. These guides have 6 mm long and 2 mm diameter pilot drills. Figure 4 illustrates a periapical radiograph of the 4.3 mm diameter osteotomy burr in place, which indicated nice positioning at the crest of the edentulous ridge. Figure 5 illustrates the deep angled threads of the Hahn tapered implant, which would help maximize initial stability. The 4.3 mm diameter implant was placed into the prepared osteotomy site. Figure 7 shows that after verifying adequate primary stability, 3 millimeter tall healing abutments were connected to the implants. Digital radiographs of the Hahn tapered implants in proper position and healing abutments in place, tissue healing following approximately 3 months of integration was remarkable. We see that the healing abutments were removed, unthreaded, and the area around the implants show remarkable healthy tissue cuffs. We see that scanning abutments designed for the Hahn tapered implant system were positioned, and a radiograph was used to verify complete seating. The buccal view of the final impression generated by the 3M True Definition digital scanner is shown in Figure 12. Figure 13 shows the occlusal view of the digital impression. And Figure 14 illustrates how the lab created virtual casts directly from the digital impression, so inclusive custom abutments and implant-retained mandibular molar crowns could be designed using CAD software. Custom titanium abutments with gold-toned surfaces and ideally contoured margins were fabricated by the lab along with the final Bruxer crowns. The abutments were seated and the prosthetic screws tightened to the manufacturer's recommended torque. Figure 17 notes the position of the margins, which are at or just slightly subgingival in order to allow easy cement removal and maintain ideal periodontal health. The Bruxer crowns were cemented over the custom abutments. Intraoral scanners streamline the restorative process by producing a highly accurate final impression that can be immediately used by the lab to design and fabricate custom abutments and monolithic implant crowns. No matter the clinician's system of choice, digital impressions reduce the cost of the restoration, result in a precise fit, and minimize the time the patient spends without a tooth.